Hey gang, welcome back. This is lecture for week number 2 or module number 2. We are going to be going over chapter 9, which is chronic obstructive pulmonary disease. And know that you guys recognize chronic obstructive pulmonary disease or COPD. We literally start talking about these patients your very first semester. The reason we start talking about them so early is because these are patients you are going to treat every single day in your career. Okay, chronic obstructive pulmonary disease is a bucket diagnosis. It can entail a bunch of different disease processes, either singularly or combined, that cause these patients to have chronic obstruction. Okay, so we're going to dig into it a little bit deeper and we're going to explain COPD and how we treat it. So the objectives of this lecture, this module, define COPD based on the World Health Organization parameters. Okay, we're going to explain the signs and symptoms of COPD. We're going to talk about the relationship of symptoms to activities of daily living. Okay, a lot of these patients, that is what they struggle with most. Okay, chronic obstructive pulmonary disease is not a curable disease or the bucket of diseases that comprise COPD. They're not curable. However, we want to maximize our patients' activities of daily living so that they can have a robust and enjoyable life. Explain the etiology and epidemiology of COPD. We're going to understand the pathophysiology of COPD and how it relates to the symptoms that these patients experience. Understand the importance of spirometry. Ooh, a very, very familiar term, or it should be. Okay, why do we do spirometry on these patients or other pulmonary function tests when we're diagnosing the ongoing disease process, when we're following the progression of disease? Why is that important? We're going to explain the importance of eliminating risk factors that can lead to COPD. So in other words, how do we prevent it? Okay. And then understand the importance of treating the patient's symptoms as it relates to that quality of life or jumping back to activities of daily living. So what is it? Chronic obstructive pulmonary disease. The lung disease characterized by chronic obstruction and airflow limitation, interfering with normal lung function that is not fully reversible. Now, I said there's no cure. I didn't say that we can't alleviate some of the symptoms. Okay, so that's what we really want to do for our patients is we want to help maximize their ventilation and oxygenation. We want to diminish their shortness of breath, and we want them to have the most robust activities of daily living that they possibly can have. Okay, COPD is the fourth leading cause of death in the United States as of when this textbook was published. The two diseases that most commonly are associated with COPD are emphysema and chronic bronchitis. Doesn't mean there can't be other diseases like bronchiectasis or even asthma that have components of COPD, but the two most common are emphysema and chronic bronchitis. This slide shows how those disease processes interact with each other. Okay, so chronic obstructive pulmonary disease is comprised of subsets of those individuals that have dominant features of three main obstructive lung diseases: chronic bronchitis, it's in the purple over here, emphysema in the red, and asthma, which is in the kind of teal color. Where they intersect down here at the bottom, you have chronic obstructive pulmonary disease. Right here, where all three of them intersect, we call that asthma COPD overlap syndrome. Okay, you're probably not going to see ACOS used as a diagnosis very often, but this is part of your textbook. It explains it a little bit more. The red box right here, okay, it focuses on areas of disease overlap with each other. Okay, patients with COPD typically have the symptoms of chronic bronchitis and emphysema, but may have some reversible airflow obstruction. That airflow obstruction due to COPD is not fully reversible. Okay, so it just depends on the patient how much reversibility they're going to have. Okay, so definition. And I think I mentioned this a little bit. We're going to go into the specific definitions from your textbook. COPD is common, preventable, and treatable. Okay, it is the result of chronic illnesses. It is the result of long-term damage to the lungs due to abnormalities of the airways and the alveoli. Okay, chronic bronchitis is defined as, and you have to know this definition, a chronic productive cough for 3 months in each of 2 successive years in a patient in whom other causes of chronic cough, i.e. bronchiectasis, have been excluded. It may precede or follow development of airflow limitation. Okay, so if you have a patient who has a chronic productive cough for 3 consecutive months in a year for 2 consecutive years. Okay, that is the definition of chronic bronchitis. Emphysema is a pathological term that describes some of the structural changes and that are sometimes associated with chronic obstructive pulmonary disease. These changes include abnormal and permanent enlargement of the air spaces distal to the terminal bronchiole. Okay, so overinflated and floppy alveoli. It is accompanied by destruction of the airspace walls without fibrosis. Okay, so emphysema, those emphysematic lungs have been inflated and hyperinflated so many times, they're like an overused balloon. Okay, so when deflated, they're kind of floppy, and when inflated, they still don't have a nice smooth surface. Okay, we talked about it last lecture, and we talked about it in diagnostics. This creates a shunt because you have perfusion going by these hyperinflated, overused alveoli, but there's not a smooth alveolar surface for alveolar capillary membrane to do gas exchange. So this is why emphysema is such a big problem. Okay, so any patient presenting with cough, sputum production, dyspnea, or a history of exposure to risk factors needs further assessment to rule out chronic obstructive pulmonary disease as the cause. Okay, this is the triad of symptoms: cough, sputum production, and dyspnea or shortness of breath that are indicative of chronic obstructive pulmonary disease. Okay, so these COPD patients have all 3 of these things, and one may be a little bit more than the other. They may have more shortness of breath than they have sputum production. They may have more cough than they have shortness of breath, but they will have all 3 of these components that make up the disease. Spirometry or pulmonary function testing is the gold standard for diagnosis of chronic obstructive pulmonary disease. Okay, so a post-bronchodilator, FEV1, okay, forced expiratory volume in 1 second, over FVC, forced vital capacity, of less than or equal to 70% confirms that airflow limitation is present in that patient. Okay, so that is a gold standard. If they have an FEV1 over FVC of less than 70% of their predicted, it confirms that airflow limitation exists. The severity of the chronic obstructive pulmonary disease is defined by both the patient's spirometry and their past medical history and history of present illness. Okay, so their reported symptoms, the combination of those two will create a diagnosis of chronic obstructive pulmonary disease. Okay, also visual observation. Okay, these patients are thin and underweight or cachectic appearance. This is very, very common in patients with emphysema. Okay, patients that are stocky and overweight in appearance, it's very common in patients with chronic bronchitis. Now, this is added to the shortness of breath, coughing, and sputum production. Okay, so you have to look at all of the components together along with their pulmonary function test. You can't just take one symptom in a silo and say the patient has chronic obstructive pulmonary disease. Okay, they may have barrel-shaped chest. They will have a prolonged expiration. Why? Because they're obstructing. So it's hard for them to exhale all the air in their lungs. Their body desperately wants to get all the used air out so it can bring new fresh air in. But they are having obstruction, so they can't get all of that old air out or the CO2 filled air. Okay, you will have, or they will have increased resonance when you percuss them. This is because they are hyperinflated. Hyperinflation causes increased resonance on your percussion notes. Their breath sounds may be decreased. They might have wheezing. They might have bibasilar crackles. They may have distant heart sounds because they're hyperinflated and there's more distance, okay, created between your stethoscope and the heart. Okay, not all of this will always be apparent, but they will have many of these signs and symptoms. Now, why do patients get COPD? Okay, cigarette smoking is the most common cause of COPD because prolonged or chronic exposure to cigarette smoke causes damage to the lungs. Cigarette smoke and other particles that are inhaled will paralyze the cilia. They will chronically generate oxidants. Okay, those oxidants activate the inflammatory genes and stimulate mucus secretion. So not only are their cilia paralyzed, but there's increased mucus secreted. Non-smokers can develop COPD due to chronic exposure to organic and inorganic dusts. The second one, alpha-1 antitrypsin deficiency. Okay, this is a genetic defect where the patient does not produce the enzyme that protects the elasticity of the lungs. When patients do not produce that, that enzyme is deficient, so the body breaks down lung tissue. Okay, alpha-1 antitrypsin is synthesized primarily by the liver and released into the bloodstream. These patients usually have never smoked. If they do smoke, in addition to alpha-1 antitrypsin deficiency, it greatly increases the severity of their chronic obstructive pulmonary disease. These patients, once they're diagnosed, they can get transfusions of alpha-1 antitrypsin, and it does cease the damage that's being caused to the lungs, but it does not reverse it. Okay, so alpha-1 antitrypsin deficiency is genetic. Okay, it is not caused by cigarette smoking or any other exposure, and it causes a breakdown in the elasticity of the lungs because alpha-1 antitrypsin protects the lung structure. Again, once they're diagnosed with alpha-1 antitrypsin deficiency, and seriously, they have a finger prick blood test to diagnose alpha-1 antitrypsin deficiency. So there's no reason that anybody should not be diagnosed with it that has it. But once they're diagnosed with it, they can get infusions of alpha-1 antitrypsin, and it will cease the additional damage. It will not correct the damage that's already been done. Etiology of acute exacerbations of COPD, they can be complex. It can include mucus plugging, it can include regional atelectasis, inhalation of environmental irritants. Okay, so if you have COPD and you're inhaling chemicals for whatever reason, it can cause an exacerbation of your chronic obstructive pulmonary disease. Changes in temperature. Okay, a lot of your COPD patients, once it gets cold, they struggle. They have a lot more issues with their respiratory system. They have a lot more exacerbations or flare-ups of their COPD symptoms. They discontinue their medications. Okay, they stop taking them. They're breathing really good. They're feeling great. They stop taking their meds. It's going to cause an exacerbation. A deviation from their diet. Okay, so these patients need a more high protein diet so that their lungs can function effectively. There's specific supplements like Pulmacare, Pulmaid, stuff that they can that are specifically low carbohydrate, so they don't produce as much CO2 in the body. That has to be eliminated. So if they deviate from that diet, they may have exacerbations from their COPD. Viral infections and bacterial infections will definitely cause an exacerbation. So exacerbations of COPD are associated with significant morbidity, mortality, decreased quality of life, and increased healthcare costs. So we always want to try to treat these patients as best as we can. Epidemiology, okay, so COPD is the leading cause of morbidity and mortality worldwide. Okay, it results in an economic and social burden that's both substantial and increasing. Again, it's the fourth leading cause of death in the United States, and COPD is substantially underdiagnosed. Okay, patients do not seek help until they are really beyond the point of receiving pulmonary rehab or appropriate medications that will help prevent them from getting worse. Pathology or pathophysiology. Changes occur in the central and peripheral airways. Okay, so we have lung damage in the lung parenchyma and the pulmonary vasculature. Inhaled tobacco smoke and other irritants can cause chronic inflammation. Okay, so we already talked about that. Some of the chemicals in the tobacco smoke, when it's inhaled, it causes inflammation in the airways. It causes increased mucus production and secretion. And it also paralyzes the cilia, so that stuff can't be eliminated from the airways. This leads to tissue destruction and impairment of pulmonary defense mechanisms. And repeated exposure to irritants cause that repeat injury and an increase in the inflammatory cells. It results in small airway fibrosis. It results in overinflation or hyperinflation of your alveoli, which causes permanent damage. And then all of a sudden, we have gone down a road that is not reversible. This lung inflammation can persist after smoking cessation or elimination of that occupational exposure because that patient's in a vicious cycle. And then the inflammation is different from what we talk about inflammation in asthma. The inflammation of COPD involves neutrophils, oxidative stress, and an excess of proteinases. Okay, all that means that in asthma, obstruction comes from bronchial smooth muscle spasming. When we give a beta-2 agonist to help relax the bronchial smooth muscle, that spasm's reversed and the shortness of breath goes away. Inflammation in COPD is permanent for the most part. There may be some reversible aspects of it, which is why giving ipratropium bromide and occasionally albuterol or our steroids to decrease inflammation. That's why those work really well for these patients. But for the most part, the damage has been done, so we have to manage the symptoms. Okay, our patients can have systemic features such as skeletal muscle wasting. Okay, this really happens because they have poor nutrition and they can't exercise. They can have an increased cardiovascular disease because their heart has to work a little bit harder in order to get oxygen to the major organs and to the periphery. Okay, our lungs are not efficiently functioning, so the heart has to pick up that extra work and work harder. They can have osteoporosis. Okay, they can have anemia, and they can also have depression because they've lost part of what their normal life is. Okay, a diagnosis of chronic obstructive pulmonary disease can weigh a toll on a person, and they can actually feel sicker even though their symptoms really haven't changed. It causes a destruction of the small airways, including inflammation, narrowing of the airways because of the inflammation, but also because of bronchospasm and because of increased mucus production. And that leads to airflow limitation demonstrated by a reduction in that FEV1 or forced expiratory volume in the first second. So these patients have moderate to severe shortness of breath on a regular basis. And that makes it difficult for them to eat and breathe at the same time. Things that we don't even think about. We don't think about while we're eating that we have to like keep our respiratory rate up, or we don't gasp on a regular basis when we are eating. But for COPD patients, they do. Shortness of breath is not conducive to eating, and failure to eat causes further muscle wasting, poor nutrition. It leads to increased work of breathing, further muscle weakness. So this is a vicious circle. This also leads them to that osteoporosis. If they aren't getting enough iron, they get anemia. And as the patient's condition worsens on a day-to-day basis with shortness of breath and inability to carry out activities of daily living ensues, that patient suffers from depression. So you can see where all of these things tie in together. Okay, the lung parenchyma destruction and capillary apoptosis. Okay, this just means that the reduced surface area for gas exchange. Okay, so the capillary does not have a smooth surface for gas exchange. It causes a VQ mismatch, ventilation to perfusion mismatch. Okay, we have a shunt. Okay, we have the perfusion. We do not have a smooth alveoli for ventilation, and this leads to hypoxemia. Okay, we have reduced airway caliber. Okay, this is caused by mucosal edema. Okay, the airways can become fibrotic. Okay, they will progressively get more fibrotic. We can have mucus impaction or mucus plugging. Have increased airway resistance. Okay, so that's that narrow airway. Anytime we're talking about resistance, it is referring to diameter of something. In this case, diameter of the airway. And it prolongs the removal of carbon dioxide because there's air trapped in the lungs. Okay, if we can't exhale everything out, carbon dioxide is being trapped. And then the elastic tissue weakens. Okay, so we have lack of elastic recoil. Okay, the lungs are not completely exhaling or snapping back into place. And this prolongs the removal of carbon dioxide. And then mucus hypersecretion. Okay, so we have an increased secretion of mucus in the airways. This is a feature of chronic bronchitis. Remember, we said 3 consecutive months of sputum production for 2 consecutive years. This is the definition of chronic bronchitis. It contributes to a chronic cough. If you have mucus hypersecretion, you will have chronic cough. Okay, it's caused by hypertrophy of those submucosal glands. So there's an exorbitant amount of submucosal glands, and they are just producing sputum like crazy. And an increased number of goblet cells in the airway. Again, they are producing increased amounts of mucus. So there's different types of emphysema that we're going to talk about. And I'm going to go over them kind of in not a lot of detail. But the first type is panlobar emphysema. Okay, this happens in the lower parts of the lung. And this is the type of emphysema that is common with alpha-1 antitrypsin deficiency. Okay, so alpha-1 antitrypsin deficiency starts in the lower parts of the lung. Central lobar emphysema is patients that have developed emphysema because of exposure either to smoke, chemicals, something in the environment. Okay, it affects the proximal respiratory bronchioles, particularly upper portions of the lungs. Central lobar emphysema is the most common and has a strong association with smoking. So panlobar, lower lungs, alpha-1 antitrypsin deficiency. Central lobar, upper lungs, associated with smoking or other environmental exposure. Okay, you have a weakening and enlargement of alveoli distal to the terminal bronchioles. And then the acinus will dilate and it will destruct. Okay, so it's just, this is all about the lungs not functioning the way they're supposed to. Okay, the alveoli are not nice, round, inflated. They don't have a great communication with the capillary. So your alveolar capillary membrane is not a smooth and well-functioning and well-oiled machine. And then we have alveolar hypoxia. Okay, so remember, hypoxia is low oxygen level. Hypoxemia is low oxygen in the blood. Hypoxia is low oxygen level. And when you have alveolar hypoxia, so low oxygen in the alveoli, you can have pulmonary vasoconstriction, okay, increased pulmonary vascular resistance, increased pulmonary artery pressures. It results in pulmonary artery hypertension. It can lead to right heart failure because it's hard for the heart to pump that blood to the lungs. And then if that continues and that right heart failure, fluid can back up and you have cor pulmonale. Pulmonary artery hypertension is another kind of staple diagnosis of COPD. Okay, each exacerbation or flare-up of chronic obstructive pulmonary disease increases pulmonary artery pressures and can cause a full-fledged pulmonary artery hypertension on recurrent episodes. So each time they get it, it gets a little worse. Now, COPD exacerbations, okay? Remember, exacerbation is just a fancy word for flare-up. It's usually triggered by bacterial or viral infections, okay? So some type of infection is triggering it. It could be pollutants, okay? Maybe the patient was in a factory zone. Maybe that patient decided to smoke a couple cigarettes. Maybe that patient was around a bunch of buddies who were smoking. Who knows? Okay, so pollutants or a combination of more than one. 30% of COPD exacerbations, no known etiology. So we don't know what caused it. They just had a flare-up. All of these patients will have an increase in inflammation in their lungs. Okay, they will become more hyperinflated because they have more air trapping. This causes them to have increased shortness of breath or dyspnea. And it can be mild, moderate, or severe. So early intervention is the most important thing. In 85% of COPD cases, smoking is the reason or is the risk factor. Okay, non-smoking risk factors for COPD include burning of biomass fuels such as wood, cow dung, and crop residuals. So you're breathing in smoke from a fire. And then chronic exposure to sulfur dioxide, carbon monoxide, nitrogen dioxide, formaldehyde, all of these different irritants or airway things that can cause irritation to the airways. And these things need to be less than 10 microns in size. If you remember back to respiratory 1010, those are the particles that get into the lower airways. And then the other risk factor is genetics. and genetics being directly related to alpha-1 antitrypsin deficiency. Complications of chronic obstructive pulmonary disease, perioperatively, so the patient's going to have surgery. They could get pneumonia afterwards. They could be very difficult to wean, so they may have to get reintubated, or they may have prolonged intubation. Once they are intubated with COPD, it may be hard to get them off. Okay, they could get cor pulmonale, which is heart failure. Development of cardiovascular diseases. We talked about this a little bit, but the harder the heart has to work, the more stress you put on the heart muscle, the less efficient it is going to be, and it can actually ultimately end up in cardiovascular disease. Patients can get respiratory infections. They're very, very prone to infection for a lot of different reasons. One being poor nutrition. Okay, and they have poor nutrition because they can't eat and breathe effectively at the same time. And it kind of just hits that vicious circle again. Some of these patients get lung cancer. And because they have lost their standard of living, they can get depressed. And depression is a huge complication of a diagnosis of chronic obstructive pulmonary disease. So diagnostic testing. So what does the chest radiograph look like? So imaging is not required to diagnose COPD. We've already talked about that. Okay, it's a bunch of different things combined. A bunch of different aspects of diagnosis combined gives us the effect or the eventual result of chronic obstructive pulmonary disease. Advanced COPD typically reveals flattened diaphragms, okay, hyperexpansion, and the heart silhouette will appear elongated because the heart rests predominantly on the left side of the hemidiaphragm. The intercostal spaces appear widened due to hyperinflation, along with an increase in the anterior posterior diameter. And the patient's retrosternal space can be increased because of air trapping. Okay, so we have long lungs, flat diaphragms, and an elongated heart. And these are kind of like the pillars of a COPD chest x-ray. Okay, said it in the beginning of the lecture, but pulmonary function testing is the cornerstone for the evaluation and diagnosis of patients that have COPD or expected or projected to have COPD. On a pulmonary function test, we are going to see a decrease in all of their expiratory flow rates. Why? Because they're having obstruction. So they can't exhale fast and hard. Okay, you're going to have an increase in your total lung capacity, residual volume, and functional residual volume. Okay, the patients are hyperinflated. They can't exhale all their air out. So because they're hyperinflated, but they still need to take a breath, take more air in to get some fresh oxygen, they are going to become hyperinflated with those flat diaphragms. Okay, so you're going to see an increase in total lung capacity, residual volume, and functional residual volume because of air trapping. And then you're going to see a decrease in their DLCO if you run that test. The diffusing capacity of the lung for carbon monoxide, DLCO, measures how easily that carbon monoxide molecules cross the alveolar capillary membrane. In COPD, the DLCO decreases with the increase in severity of the disease due to the lower amount of surface area available for diffusion. Again, that takes us right back to that oddly shaped alveoli that's been hyperinflated, and it's like the overused balloon, and then your capillaries coming by it, and there's not a smooth surface for gas exchange. Okay, so that's why you have a decreased DLCO or a decreased diffusion capacity. Now, this is talking about the Global Initiative for Chronic Obstructive Lung Disease, or the GOLD standards. And some of you may have come in contact with this. At clinic, there are a lot of hospitals that use the GOLD standard. It is a way to classify airflow limitation severity in COPD patients. okay? These patients all have an FEV1 over FVC of less than 70% predicted based on their post-bronchodilator FEV1. So this is not pre-bronchodilator. This is post-bronchodilator. Okay, so gold standard or gold classification 1 is mild COPD. Okay, their FEV1 is greater than or equal to 80% of predicted. Gold standard 2, which is moderate, is 50 to 80% FEV1. So let me take a step back. Gold standard classification number 2, or moderate severity, is an FEV1 of 50 to 80%. Gold standard number 3, or severe COPD, is 30 to 50% of predicted, and gold 4 classification is very severe or less than 30% of predicted FEV1. These are guidelines for COPD diagnosis and classification of airflow limitation severity. Airflow limitation that is irreversible or only partially reversible with bronchodilator is the characteristic physiologic feature of COPD. In other words, very little of airflow obstruction can be reversed in patients with COPD. Okay, this is the quintessential obstructive flow volume loop. Okay, so here in the red, you have a normal flow volume loop. Okay, you have inhalation, exhalation, oops, sorry. And then the inhalation would come again at the bottom. Okay, here you have that patient inhaling and then exhaling forever and ever 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 because they have an obstruction. Okay, so when you have the ski slope, okay, or other people have called it the skateboard ramp, okay, that is very indicative of chronic obstructive pulmonary disease. Now, part of the multifaceted assessment is the COPD assessment test. Now, the COPD assessment test is an 8-item measure of health status impairment in COPD. Okay, this is a very subjective assessment score. Okay, it takes all of these different 8 criteria, and patients will rate how they perceive they are doing on a scale of 0 to 5. 0 being the worst ever, 5 being the best, or I'm sorry, 0 being the best I've ever been, 5 being the worst I've ever been. Okay, so in frequency of cough, 0 means I never cough, 5, I cough all the time. Amount of phlegm or mucus produced, 0, no mucus at all, 5, tons and tons of mucus, and so forth and so on. Tightness of chest, breathlessness during walking or climbing up a flight of stairs, limits on their activities of daily living, like can they do basic cleaning? Can they go out in their garden? Can they do they feel comfortable, or do they have the ability to fold clothes and do laundry? Okay, confidence venturing outside of the home. Okay, can they go to the grocery store? Do they feel confident going to the grocery store? Do they feel confident going to their grandson's baseball game? Okay, quality of sleep. Again, this is all 0 is the best, 5 is the worst. And then level of energy. Okay, the scores range from 0 to 40. And this COPD assessment test, or CAT score, gives you kind of a way to track a patient and how their perception of their disease is. Okay, it is not objective in any way. It is purely the patient telling you how the disease is affecting their daily life. Okay, this next one is called the ABCD assessment tool. Okay, I personally have not used this. However, it combines the GOLD classification, assessment of airflow limitation. Okay, so that's that. And then the assessment of symptoms, risks, and exacerbations. So it's combining a bunch of different tools together to kind of determine where you think the patient is or where the patient feels that they are. So step one is in the process is confirmation of the diagnosis of COPD. Okay, and this is purely going on the FEV1 over FVC being less than 70% predicted. Okay, so post bronchodilator, if your FEV1 or FVC is less than 70% predicted, that gets one check mark. Step two is the assessment of airflow limitation. So this is our GOLD standard or our GOLD classification. This is only looking at your FEV1, your percent predicted. If it's greater than 80% predicted, category 1, 50 to 79, category 2, 30 to 49, category 3, and less than 30% predicted, it's category 4. Okay, and then step 3 is the assessment of symptoms using either the dyspnea scale or the CAT. So we've talked about the CAT. We didn't talk about the dyspnea scale, but we're just going to say we're going to use the CAT. Okay, so it combines that and hospital admissions. Okay, so we're going to step 4 is the classification of exacerbation history. Using the symptom assessment and the exacerbation history, it classifies the patient in one of 4 boxes. These groups are used to determine treatment. So if you have had greater than or equal to 2 or greater than 1 leading to a hospital admission, I'm talking about exacerbations, and your CAT score is less than 10, you're going to be in box C. If you've had 0 or 1 exacerbations, none of them leading to admissions, you're going to be in box A. If you've had more than 2 exacerbations and any admissions, and your CAT score is above 10, okay, so that means you perceive that you're pretty short of breath, you're going to be in D. And if you've had no admissions or no exacerbations and your CAT score is above 10, you're going to be in B. So it takes all of these into account to kind of look at the severity of the patient's disease. Now, diagnostic testing. Okay, so we've talked a lot about PFTs. There is no pure laboratory testing for COPD with the exception of alpha-1 antitrypsin. Okay, patients that are exhibiting the symptoms of COPD should have an alpha-1 antitrypsin test because they can get infusions to get boosts or boluses of alpha-1 antitrypsin. Now, once you start on that, you have to have it forever. Any patient diagnosed with COPD should have the test for alpha-1 antitrypsin, especially if the patient is 45 years or younger. Okay, so these are patients that are exhibiting COPD symptoms very early in life. You should have laboratory testing to rule out other causes of the symptoms. If you have a BNP, it'll help rule out heart failure, and then a constant check of hemoglobin. Okay, so dyspnea can be caused by low hemoglobin. However, you will not have the increased sputum production. Polycythemia can be seen as it's compensatory for chronic hypoxemia. So again, diagnostic testing has to be run to kind of rule out other diagnoses. Treatment and management of COPD. Okay, we want to relieve their symptoms. Okay, relieve the symptoms of cough, of airflow limitation, of sputum production. We want to improve their exercise tolerance. Okay, so we can do that through pulmonary rehab. We want to minimize their exacerbations by educating the patient on what to avoid, what lifestyle changes that they could make to help maximize their activities of daily living. We want to prevent that disease progression by getting them on the right medications and getting them on the right exercise regimen and teaching them how to breathe efficiently with pulmonary rehab. And all of this will reduce mortality if the patient buys into it. Long-term treatment, okay, we love our long-acting beta agonists, okay? Long-acting muscarinic receptor antagonists, so our LABAs and our LAMAs. We have a lot of combination inhalers out there, LABA and LAMA combined, so it's less medications the patient has to take, less often they have to take them. Very effective are our LABA and inhaled corticosteroid combinations. Okay, and very often our patients are on those triple meds, the LABA/LAMA inhaled corticosteroids. Some patients, phosphodiesterase inhibitors will work. And some patients, even methylxanthines, although they aren't used very often anymore. So here's some of our LAMAs. We've talked about them in Pharm. I don't need to talk about them again. You guys can read them. Okay, LABA/LAMA combinations. Okay, LABA/ICS combinations. Again, you guys can read these. These are the really ones patients really like, the vilanterol, umclidinium, and fluticasone, okay, combination. So those are really good. And then roflumilast, those phosphodiesterase 4 inhibitors, those only work on a very, very small percentage of patients. And then again, theophylline or methylxanthines only work on a very small population of patients. So based on that ABCD assessment tool, the box, okay, group A, they really don't need much, okay? They just treatment of breathlessness, okay? A short-acting beta agonist rescue inhaler or a long-acting beta agonist that they take once a day or twice a day. That's really all they need. Group B's, they need either a long-acting beta agonist or long-acting muscarinic antagonist. And for COPD, especially for emphysema patients, the muscarinic antagonists seem to work better. Okay? They prevent that bronchoconstriction, not actively treating it, but preventing it. If the symptoms persist, even though they're in that group B treatment category, a combination LAMA/LABA will really treat these patients well. Group C, using only a LAMA, okay, because there's no, the reversibility isn't there. So why give them a beta agonist when the reversibility isn't there? If the symptoms persist and they don't get better, then a LABA/LAMA or a LABA inhaled corticosteroid. And you notice that inhaled corticosteroids only come into play when patients are more severe. And then group D, these are our most severe patients, the ones who've had the most exacerbations, the ones who have the most limited airflow. You begin with the LABA/LAMA combination, and then if the symptoms persist, don't get better, you add in the inhaled corticosteroid. And then you can also try those phosphodiesterase 4 inhibitors or other medications. Okay, but these C and D, these are our most affected patients and the ones that need the most support. Alpha-1 antitrypsin deficiency, depending on where they sit in the ABCD, those drugs may or may not help them, but what they need is they need the replacement infusions. There's several different ones, Prolastin C, Aralast, Zemera, Glacia. Those drugs are administered by infusions, and those drugs will help cease the progression of emphysema by replacing that protein and helping to have enough of the protein that the elastin in the lungs do not get broken down. Non-pharmacological measures, okay, smoking cessation education, okay, physical activities such as pulmonary rehab, making sure they get the flu vaccine and pneumococcal vaccines, all these different vaccines they can get that help prevent them from getting sick or having an exacerbation. And again, I think pulmonary rehab for all of them. This says for groups B through D, but everybody can use a little pulmonary rehab. Long-term oxygen therapy. Commonly used for stable patients with COPD, PaO2 is less than 55 or SpO2 is less than 88. Most of our patients, physicians want to keep them 88 to 92. It's a very comfortable range for our COPD patients. This will increase their survival rate. It decreases their work of breathing. It decreases their myocardial workload. The heart doesn't have to work as hard. So it's all good all around for COPD patients. And then non-invasive positive pressure ventilation might be used for severe COPD with daytime persistent hypercapnia. Okay, so these are our really sickest of the sick, the ones have progressed very far along in the disease state. And then some patients will do what's called lung volume reduction surgery. Now, this is an extreme measure. However, the very, very extremely damaged parts of the lungs are cut out. Okay, giving the rest of the lungs the ability to take over. Okay, because air is always going to follow the path of least resistance. So our hyperinflated, our overinflated areas, that's where a lot of the air is going to go. So lung volume reduction surgery occurs in patients with low exercise capacity. They take parts of the lungs out that are most damaged. It will reduce hyperinflation and it increases elastic recoil pressure of the lungs. So just overall, the lungs work more efficiently. Treatment of exacerbations include the initial or acute treatment with short-acting beta agonists and short-acting muscarinic receptor antagonists, or DuoNeb, Compavent, those drugs that we give every day. Antibiotics, only if infection is present, but I will guarantee you that most of your COPD patients are going to get covered with antibiotics because they still don't know what's growing. They don't know what's happening. Careful of comorbid conditions and drug interactions. So got to watch what we're giving the patient. Keeping those SATs 88 to 92, giving them corticosteroids, hospitalization if necessary, and then in extreme cases, non-invasive positive pressure ventilation or mechanical ventilation. However, we try not to do that because it's hard to get patients off once you put them on. Prognosis is, and again, I said this before, there's no cure. However, we can slow down the progression, and that's what we want to do. Each exacerbation increases the chance of mortality in the patient. And this is another index or another scoring tool. Okay, so the Bode index is used to approximate a COPD patient's 4-year survival rate. Okay, and it takes into account their BMI. Okay, so if it's greater than 21, a 0, less than 21, a +1. Airway obstruction, okay, this is the classification, their FEV1, their dyspnea scale, okay, and this is all perceived. So do they get short of breath when hurrying or walking? Do they walk slower than people the same age? Do they stop for breath after walking 100 yards? They're too dyspneic to leave the house, okay? And then exercise tolerance. This is a 6-minute walk. How long can they go? A score of 0 to 2, it gives an 80% 4-year survival rate. A score of 3 to 4 gives a 67%, 5 to 6 a 57%, and a score of 7 to 10 only an 18% 4-year survival rate. So, it just gives us an idea of how that patient's going to do. All right, that is the end of COPD. Make sure you do the discussion board and have a great week.